All right. Really? No. That reminds me, please mute your phones. All right. So, welcome. For those who don't know me, my name is Sarah. I am the Executive Director of PARC. We are here today for the second session of our third annual Parkinson's Educational Day, brought to you by PARC, APDA, and University of Virginia Neurology Department. Clicker. So, this is the order. We're going to try to stick to it as best as we can. In our first session, we went over a little bit, but we made it up. So if we are running a little bit late, don't worry, we have some time built in. I will let you know that the 2:30 to 2:45 session is going to be virtual. The person can't make it in, so we'll broadcast it online. Also, we are recording the session, so if you wanted to go back, we'll send out the recording in about a week or so. So I want to thank all of our sponsors here today. We have, well, in order, AbbVie, we have Amari Peeler over there. And for Medtronic, we have Kate Campbell. For our silver sponsor, we have Amneal, and that is Jack Anderson. For our bronze sponsors, we have Trey from Boston Scientific. And we have Bryn from Supernus. And Joel is in the middle. Joel is from APDA. They also helped put this together. We also have a bunch of UVA doctors here, a bunch of UVA neurology staff members here as well, who are here volunteering and help put everything together. We also have, so APDA, PARC has a table in Eckham. No, yes? Akeem? Okay, Akeem is here. She's a PhD candidate. She is doing a tremor trial at UVA. Say that 5 times fast. She's gonna, hopefully we can get you in maybe after Gina's presentation, if that's okay for you, Gina. Gina? Okay, get her in so that way you guys can get some information about her trial at UVA. Again, she's a PhD candidate. All right, guidelines for the day. After each presentation, we are going to have a few minutes for question and answer. 10 minutes was a bit of a stretch, so may not be 10 minutes, maybe 5 minutes. And please keep all your questions to the end of the presentation. And then please respect all questions that are asked and how they are answered. We will have one 15-minute break throughout the afternoon, but you're more than welcome to take a break as you need to. Please exit through that back door so there's not a whole lot of interruptions at the front. All right, on your table, hopefully there's still copies of a survey. Please fill that out at the end of the day, and we'll tell you where to drop it off. All right, we're going to get laughing a little bit. For those who are this morning, don't mess it up. All right. For those who are PARC members, you kind of know what I may be doing right now. I want you to please repeat every line that is on this board as loud as you can. Did anybody cuss? Oh, wow. Nobody cussed in the first class either. That's very rare, right, Martha? Very rare for someone not to cuss. All right. So you guys are free to go back out. All right. So I'm going to do a little bit of introduction. Like I said, my name is Sarah. I'm the executive director of PARC. We're here in Charlottesville. We focus on exercise support, education, and socialization for those with Parkinson's disease. Some of you all are current members of us. Wow. And if you're in the Charlottesville area, reach out, and we would love for you all to join us. So what do we offer? We offer yoga, we offer rock steady boxing, support groups, quarterly topic-based speakers, the educational event, and social activities. Yoga is offered twice. One of our volunteers today is one of our yoga teachers, but she had to step out. So it's offered twice a week for both people with Parkinson's disease as well as care partners. They modify for all injuries. It's seated, standing, and there's also ground exercises as well. Rock Steady Boxing is one of our most popular classes that we offer. It's the one that we offer the most during the week. It's an hour-long session. It's non-contact boxing, so don't worry, you're not going to get hit. But it's not just boxing. We do so much other stuff. There's strength training. There's flexibility. We offer classes currently Monday through Saturday. Wow. Level 1, level 2, level 3, 4. And for those who have cognitive decline, it's also one of our classes. We have 4 certified coaches. We work on strength, coordination, cognition, balance, core, flexibility, everything that you may be losing because of Parkinson's. We try to either maintain it or get you better at it. And we also like to do a lot of fun games. So we'll do board games. We have Blaze Pods, which is a light reflex contraption. Why do we box? So everything, apparently there's a laser. Everything that's on your left side is what you all may be experiencing with your Parkinson's. Everything that boxers train and what we try to help you with counteracts everything. So tremor, we try to work on your hand-eye coordination. For your bradykinesia, we try to work on your speed of movement. Our support groups, we offer 2 separate support groups. One of them is for our early onset. It's on the second Wednesday of the month, and we offer that hybrid. We also offer our regular support group. That's on our 3rd Tuesday of the month, and that is offered in person. And then another option is at 6 o'clock on Zoom. We also offer our quarterly based speakers. So speech and language pathologists, nutritionists. We had UVA medical students coming in and doing CPR training. We had a social worker came in and talked about mental health. And on May 19th, we're having a lawyer coming in talking about estate planning, powers of attorney, things of that nature. Our educational events, you're here right now because of something that we are offering. In 2024, we were at UVA Darden School. We had about 65 people in person. 2025, we had 100 people in person, all in one room at the same time last year here. And then this year, we split the 2 separate sessions. And then in 2027, maybe we'll be at like 150, who knows? We also do social activities. So we did bingo, we've done bowling, we've had potlucks, we did baseball games. We just did sunpin bowling about a month ago. We had about 60 people going out to sunpins. And these are just a couple of quotes from a couple of our boxers. And actually both of these, Pam had been only with us for about maybe 6 months when she said that. And then Jeff had been with us for a couple of years. We're located across Lowe's, across 29 from Lowe's and Chick-fil-A in the same building where US Cellular and Play It Again Sports are. So how do you get involved? Call me, email me. Don't call me late at night though. And then you'll fill out some intake forms, and then we'll get a medical release form signed from your neurologist. If you're a patient at UVA, then they have that. All you got to do is send a message on my chart. They'll get it over to me within about a week or so. All right. Are there any questions for me? I know it was quick. We have a lot of stuff to go through. Anybody? All right. Next person will be Joel. Joel is from APDA.
Thank you very much, Sarah. I appreciate it. Hello, everybody. Good afternoon. My name is Joel Frondelli. I am excited to be here on behalf of the APDA Virginia chapter. By day, I am a behavioral therapist. By night, I sit on the board, and it is exciting and an immense privilege to be here and see all of you and participate in this education day today. If you are unaware of the APDA, we have an origin story, like so many of us individuals. We began in 2 ways, the Richmond chapter and the Virginia Beach chapter. Over time, one of them fell off and the other grew into the Hampton Roads chapter. Further in our timeline, in 2022, we encompass the entire state of Virginia. It is now a great responsibility that we all share to see and hear and touch and help and empower from sea to mountain here in Virginia. The APDA can offer many things to you. Primarily, it is a resource of referrals to connect you with your community, with fringed communities outside of your area. We like to think of ourselves as the one-stop shop for all things Parkinson's disease here in Virginia specifically. We have our own support groups, but we also empower and support and help ignite support groups that come about in and of themselves all throughout the state. We have a Rolodex of over 40 kinds of educational materials and pamphlets at your disposal for free. These can come in digital copies. They can also be physical copies. I have a handful at my table. They can also be sent to your respective areas, your office, your home, etc. The APDA also offers a financial hardship program. Approved applicants will be awarded a scholarship to cover expenses, which may include assisted devices, medications, adaptive equipment, etc. Our statewide support groups, the virtual APDA newly diagnosed support group. This happens on the fourth Thursday of the month from 5:30 to 6:30. We also have a generalized Virginia Parkinson's resource group, and this happens every Wednesday from 10 to 11 a.m. These respective resources, these emails, you can find at my table, and I can connect you with them. I will take a picture now. I'll leave it up for just a moment. Wonderful. Some of the programs I'd like to highlight here today are our newly diagnosed education and support programs. This is the Good Start and Press program. These are for newly diagnosed individuals, and they help empower and support their caregivers and loved ones along their journey. This is accompanied by our wellness webinar series, which are different kinds of educational presentations featuring different experts from different fields, from yoga to dance to meditation, etc. We ourselves also put on education days all throughout Virginia, and like today, we support the ones happening in your local community. Virginia, the APDA Virginia chapter hosts the Virginia Parkinson's Conference. This is the statewide resource for all things Parkinson's disease from the leading experts of our fields here. It is hosted currently at the College of William and Mary, the College of Education, down in Williamsburg, Virginia. There's also a secondary conference that happens in Roanoke, Virginia. For our national education, this can be found online on our website. It is spearheaded by Dr. Gilbert, and right now she is reviewing pre-motor Parkinson's disease events. If you cannot see the smaller sub types of educational digital materials, we have dance for Parkinson's disease, chair fitness, virtual Tai Chi, singing loud for Parkinson's disease. Like I said, Dr. Gilbert hosting the pre-motor Parkinson's disease webinar and virtual yoga. The APDA is quite proud in its long-standing practice to support research. From the early 1960s, over $68 million has been handed through the APDA to support research. Such research grants involve the Diversity in Parkinson's Disease Research Grant. This addresses health inequities and/or differences among understudied Parkinson's disease communities, ethnicities, ancestry, geography, socioeconomic conditions, and gender. Other research grants relate to the relevant problems of Parkinson's disease, the causes, some prevention practices, diagnosis and treatment plans, all and other related neurological movement disorders. For local research, Virginia healthcare professionals and other researchers with credible IRB studies can reach out to us for help in their recruitment process, find participants. The APDA as a whole has been a longstanding advocate for all of those with Parkinson's disease, and what is exciting now is our new Chief Public Policy Officer, and formerly internally the Vice President of Federal Relations. This person is available to you. They will be frequent at Capitol Hill. Some of the events that they are reviewing on Capitol Hill are Paraquat. Syngenta is the largest producer of Paraquat, and they have just announced that they will stop producing it this year. This is a big thing for the Parkinson's disease community, as it has been linked in multiple studies to increase PD risk. This is not a ban, unfortunately. It still remains legal and in use in the United States, but is a step in the right direction to prevent needless harm upon our communities. Another event happening on Capitol Hill is the Bipartisan Healthy Brains Act. This was introduced recently. This major new federal bill represents a significant federal investment and would establish research centers focused on toxic exposures and brain health. The legislation is a critical step towards safeguarding millions of Americans, millions of Virginians living with a neurodegenerative disease today, and to safeguard and protect future generations from obvious preventable risk. The last thing I would like to highlight that's going on in Capitol Hill is the Veterans with Parkinson's Your Voice is Needed effort. The Department of Veteran Affairs is reviewing right now whether additional toxic exposures should qualify for presumptive services connection for Parkinson's disease. What this would do is reduce the burden of proof for veterans, speed disability compensation access, expand VA healthcare eligibility, and improve quality of life, ultimately, for veterans with Parkinson's disease. There are many ways to be involved. Often you are yourself already involved. It is just the connection with myself or someone within the APDA that connects you with us. Become a volunteer, join our board, become a committee member. Let us know about your support group. It is your knitting group, just composed of people with Parkinson's disease. Sometimes these things are disguises for support groups, and they're just fun events. You can connect with me at our table. I have many resources and flyers at your disposal. This is information for you, free to access. This is some of us. What this is highlighting now is our optimism walk. These happen all throughout Virginia. This year, we have two coming up, one in Norfolk and another in Port Suffolk, Virginia. We also have them happening in the past in Fredericksburg, Roanoke, Virginia, Salem. And these can be put on by us. These can be put on by a community leader, and we come in and support you with the most relevant materials. and help set up the infrastructure for your walk. It's so lovely to see everyone this afternoon. If you have any questions, I am here all afternoon. Stop by my table. I have a handful of information for you. It's all for you. That's why I'm here. Thank you very much.
Does anybody have any questions for Joel right now? For example, someone asked, how does someone who's a veteran get answers from the first session? Any questions at all? If you do, raise your hand and we'll bring the mic over to you. Going once, going twice. Thank you, Joel.
Thank you very much. Have a wonderful afternoon, everybody. See you soon.
And Joel will be out in the lobby during our breaks, okay? So the next presenter is Dr. Christina Kane, who is from UVA Neurology Department. Come on up.
Yep. Can you guys hear me? Perfect. Yeah, for those who don't know me, oh, actually, before it's this one right there. Okay. I'm Christina Kane, so lovely to meet you if I haven't met you before. Today we're going to talk about some of the non-motor symptoms in Parkinson's disease. There's a lot of non-motor symptoms, but I was going to focus on something called dysautonomia, which I think a lot of you all are probably familiar with, but may not have heard the actual term. So I'll define it for you guys and kind of walk you through what that means and how it might affect you on a daily basis. So first, I'm just going to do an overview of what we're going to talk about. So first, I'm going to define dysautonomia. I'm going to go through all the common signs and symptoms of it, and then I'm going to talk about very specific ones, the most common ones that people experience with Parkinson's disease. So one of them is neurogenic orthostatic hypotension. I know that's a long word, but don't worry, I'll tell you what it means. And then neurogenic bladder. We're going to talk about constipation and gastroparesis. We're going to talk about the usual testing that we do for dysautonomia and then how we manage this. So what is dysautonomia? So this is when the autonomic nervous system isn't functioning appropriately in the body. The autonomic nervous system controls these automatic functions in your body. Things that you don't really think about, like your blood pressure, your heart rate, particularly when you're changing positions, your bladder function, bowel function, and many other things like temperature regulation, and many more. And this is super common in Parkinson's disease. It doesn't usually manifest in the beginning, but as things progress, this can become more and more of a problem. So ways that this can manifest from a symptomatic standpoint. So people can feel dizzy when they stand up suddenly, or especially in the morning when they first get up out of bed, or if they've been really dehydrated and they get up from sitting for a while, they'll feel dizzy. And it's more so kind of this faint feeling, lightheadedness, feeling like things are darkening and like you're going to pass out. Constipation, bloating, nausea. Some of this can also just be associated with certain medications, urge to urinate more frequently, trouble emptying your bladder fully. Of course, there are other causes of this too. Sexual dysfunction is common, leg swelling, abnormal sweating, temperature dysregulation. And know that these can vary from person to person. So not everybody experiences dysautonomia the same way. So what is neurogenic orthostatic hypotension? So this is where when you stand up suddenly or you change positions, your autonomic nervous system isn't functioning appropriately to make your blood pressure and your heart rate change based off of the position change. Normally, when you're laying down and you sit up, your body has to push the blood a little bit harder to get it up to your brain because now you're not flat. It has to work a little bit harder. And sometimes as we age, and also with certain neurodegenerative conditions like Parkinson's, that just doesn't happen as quickly. And so this causes people to feel dizzy. And as I mentioned, it's more of that lightheadedness. Not usually the room spinning sensation, but sometimes patients will say that they feel that as well. And we'll talk about how to manage these things at the end. So neurogenic bladder, this is also very common. So normally your bladder has, robust communication with the spinal cord and the brain. Again, this is something that just happens automatically. You're not really thinking about it. But when this isn't functioning well, this can lead to feelings of sudden urgency. You know, you're okay, then suddenly it hits you that you have to go to the bathroom and you're running to the bathroom. Having to also go more frequently, even if you're not necessarily changing how much fluid you're drinking. Difficulty emptying your bladder. So you feel like you go to the bathroom, you empty your bladder, but then you're back in the bathroom again a few minutes later. And all of these can even lead to incontinence where you're having accidents. It's really important to manage this. First off, it affects quality of life, but also it can lead to urinary infections and even kidney damage. So it's definitely important to pay attention to and not necessarily just attribute it to age. So constipation and gastroparesis. These are two things that tend to co-occur. So, in Parkinson's disease, it's not just your movements that slow down, but your gut can also slow down. And so what's the difference between constipation and gastroparesis? So constipation is where you have trouble passing stool, you have less stools, and then the gastroparesis is actually the slowing down of the emptying from the stomach. And again, they co-occur. A lot of people with Parkinson's have gastroparesis. This can have major impacts on your quality of life. It makes you feel bad. You're having bloating, nausea. It can affect your appetite. And, especially if you're having more tremor, it can lead to weight loss. You can have issues absorbing your medication. So especially with carbidopa, levodopa, it's important that your gut is cycling, quickly. Because people can start having motor fluctuations. If you take your medicine, your gut's not moving quickly, that dose of medicine is going to kind of hang out and might not even get processed or absorbed. And then you take your second dose and then both doses get absorbed and then you're having too much movement. So it's very, very important to keep an eye out on constipation and make sure you're going every day to every other day. And then in more severe cases, this can lead to bowel obstructions, which is life-threatening and may need surgery. So what do we do for testing? Usually, it's more so us asking you how you feel and you letting us know if you're having any of these symptoms. There's a lot of things that we can do, both medication and non-medication treatment options for this. And then also in our physical exam, we can tell, if you're having some of these symptoms when we ask you to stand up. If you get dizzy, we're getting a sense that you're having some of this orthostatic hypotension. We can check your blood pressure and heart rate in different positions while you're in the clinic to see if this is happening. And sometimes, this varies. Maybe that given day, your blood pressure and heart rate are okay, but maybe in the morning when you're getting up, this is happening. There are a lot of other tests that can be done for dysautonomia as a whole, but we don't necessarily have to do those things. We trust you when you say that you're having constipation, we're going to help you treat that. So you don't have to go to a center that does all this fancy testing necessarily. So now taking each of these and talking about different options for treatment. So non-medication options for neurogenic orthostatic hypotension. First off, the easiest thing that you can do is just take your time when you're changing positions. Avoid sitting or standing for a long time, which, hopefully you're exercising and moving throughout the day so this isn't happening. Make sure that you're staying well hydrated. And as long as you're not having any cardiac issues, making sure that you increase your salt intake. You can use compression stockings, abdominal binders. For the ladies, if you want to use Spanx, that can really help. And also when you're laying in bed, elevating the head of the bed. And one thing I tell my patients is, especially if this is an issue in the morning, have a glass of water by your bedside. So as soon as you wake up, you just drink a big glass of water, give yourself a little time for that to process through your body, and then get up. And that way you don't feel so dizzy. And then also making sure that with each meal that you just drink a big glass of water if you're having trouble keeping up with your hydration. If you're drinking a big glass of water in the morning with breakfast, lunch, and dinner, that's a lot of water. You just make it your goal to finish it during that meal. And usually that's enough, doing these sorts of things. But sometimes we have to use medications. And so I have listed here the most common medications that we'll use. So you may have heard of midodrine, fludrocortisone, droxidopa, and pyridostigmine. We usually try one of these medications. We all have our favorites. There's pros and cons to these medications. So a lot of times people with Parkinson's may have high blood pressure, but then as Parkinson's is progressing, maybe people aren't having as much blood pressure issues. Usually before we even try some of these medications, we might even stop one of the blood pressure medications. Or if you're on a medicine like propranolol that affects your heart rate, we might need to also lower that or stop it. And sometimes patients need both. They need high blood pressure medication and then one of these medicines to help boost their blood pressure medicine. It can get a little tricky. These medications kind of help boost your blood pressure, and we usually prefer that you take them earlier in the day so that they're not affecting you in the evening, because they can cause something called supine hypertension. Supine being that you're laying flat and then your blood pressure can get up really high. That's why we tell you don't take it, in the evening or around dinner time, because that if your blood pressure is too high at nighttime, it can put you at high risk for a lot of different things, particularly stroke, heart attack, stuff like that. And usually, a few of these medicines do that. Pyridostigmine, not quite as much. But yeah, these medicines can be very helpful. And sometimes we have to combine them. Now, managing neurogenic bladder. This can be tricky. One thing, we're telling you to stay hydrated, so that can be really difficult and make you have to go to the bathroom more and more often. So just making sure that when you're staying hydrated, that you're doing that earlier in the day. One thing that I'll tell people too is that after dinner, don't drink anymore unless you have to take medication, so that you're not up going to the bathroom all night long. A lot of us, if we're busy, you're going all day, you're dehydrated, then you remember that you're dehydrated in the evening, you drink all your water in the evening, and then you're up all night. So try to make sure that you take your breaks during the day to go to the bathroom, and maybe even plan it to help prevent a sudden urgent bathroom break. And then also, to help prevent urinary infections, cranberry juice can be helpful in preventing them. Sometimes people need to be on antibiotics prophylactically, meaning to prevent urinary infections in the future. And then in terms of medication options, so a lot of times, us as neurologists, we're not necessarily prescribing these, but we'll tell you to go see your primary doctor to talk about this. And sometimes there's other conditions that are also impacting the bladder. Some of the more common medications are like Flomax and oxybutynin. These are good medicines, but they can cause some issues and some side effects. So for example, the oxybutynin can cause dry eye, dry mouth, can worsen constipation, and it can even cause confusion. And that's just part of the way that this medicine works. It can cause a lot of these symptoms, and especially if there are cognitive symptoms, it makes me a little bit nervous. Then tamsulosin or Flomax can also lower blood pressure and cause people to get even more orthostatic. So we have to be mindful of that if people are dizzy. There are two other medicines that tend to have a little less of these side effects, though they can be expensive. Vibegron and mirabegron. These are newer medications. They're a lot more specific to the bladder muscle, so they don't tend to have all of these other systemic side effects, meaning that it's affecting the rest of your body. So they're really, really good. And I'll tell people, if we've tried the non-medication things, we have barriers to trying some of the other medications. maybe they should go talk to their primary doctor or their urologist about the vibegron and the mirabegron. And then sometimes the patients need Botox. We do lots of Botox, but we don't Botox the bladder. So it may be that you need to see somebody who does that. Constipation. I would say that this is probably the symptom that I see the most. Just about everybody has constipation, even in early Parkinson's disease. And so again, just kind of highlighting how important it is to stay hydrated, because that really helps move things along. And again, you know, a lot of people struggle with staying well hydrated. And one thing I'll say with that too, there's not a really good, you know, number or, you know, amount of fluids that you should be necessarily trying to achieve. It depends on your body. There's many factors in that. But what I like to tell people is also to make sure that when you're going to the bathroom, that your urine isn't very yellow, because that means that you're dehydrated. Make sure that you're not overdoing it on the caffeine. So have, you know, a cup of coffee in the morning, but try not to do that all throughout the day, because that can also irritate your bladder. And it's also dehydrating. Now, also physical activity can really help with this. It promotes bowel motility. And then there's certain foods that can really help. Fiber is really good, but you also have to make sure you're hydrated, or it can even make things worse if you're not drinking enough water. But prunes tend to be pretty helpful. And another one that I didn't include here are kiwis. And then there's a lot of different medication options. And I do get a lot of questions about, you know, what's the best stool softener, or, you know, medication for constipation. And everybody's a little different. Sometimes people are pretty regular and they just need something as needed. Sometimes people have to take something regularly. So I have a list here of the different medications that we tend to recommend. And I also wrote down how they work. So for example, Docusate or Colase is a stool softener. Then you have stimulant laxatives like Senna or Senecot and Dulcolax, and they stimulate the intestinal muscles to get things moving. There's also something called osmotic laxatives. That's the Miralax, the powder. And then lactulose, which we don't always use, and milk of magnesia. So magnesium can be very helpful for this. This softens the stool. It increases water in the intestines. And then there's also fiber, as I mentioned, so it kind of bulks up the stool, Metamucil, and also promotes kind of bowel movements. And I say fiber should be used with caution primarily because you need to make sure you're hydrated. And then sometimes we have to use suppositories and enemas. But I would say that I would stay away from those and try these things before you jump to that. All right, so that's kind of an overview. I know there's a whole lot of other non-motor symptoms, but I really wanted to make sure that people were familiar with dysautonomia. There's a lot here, and I just kind of highlighted the very basic, kind of most common symptoms that people will have in Parkinson's disease. I did create a cheat sheet, and sometimes I'll give some of my patients this cheat sheet. The cheat sheet says multiple system atrophy, which is a rare Parkinsonian syndrome that can mimic Parkinson's disease. So I had made that for one of the organizations, Mission MSA, and I'm working to make this specifically for Parkinson's disease so that we can hand them out a little bit more readily in clinic and not confuse people. If you're in clinic with me or with any of us, you can always ask for this cheat sheet and we'll print it out for you. All right.
All right. We got a mic coming.
What are the cautionary aspects of psyllium husks and other non-nutritive fiber? You said use with, there was a
Yeah, just the caution is, you don't want to take in a lot of fiber and have no water, because it can actually block you up. So that's the caution part. And since a lot of people have trouble staying hydrated, they don't feel thirsty, but then they start taking in all this fiber, it can just make things worse. So yeah, that's the caution part.
Are there any over-the-counter meds for overactive bladder, or do you have to go right to prescriptions?
Yeah, I don't use any over-the-counter medications for overactive bladder, or don't recommend them necessarily. It's more so a conversation with your primary doctor to talk about these different options. I'll say I'm not the expert in the bladder stuff, so usually talk to the primary care doctor. Mhm.
Could you explain a little more about abdominal binders and gastroparesis? How do they work? Where would we get one?
The abdominal binders. So that would be more so for the orthostatic hypotension. So the reason why the stockings and the abdominal kind of compression stuff works is because, so when you're trying to get blood from your legs up to your brain, your veins are pumping that back up to your heart, right? But the veins are not as strong as the arteries in terms of pumping. They actually rely a lot on muscle activity to push the blood back to the heart. So that's why it's so important for you to stay physically active, because it actually pumps that blood back, helps with swelling. And so the thought is with these compression stockings, which you can get either knee highs or thigh highs, although these can be quite uncomfortable for some people, is that it's kind of squeezing those muscles and helping to squeeze the blood back up. So the abdominal binders, compression stockings can be found over the counter at a lot of pharmacies. The abdominal binders can be a little bulky. They do tend to work a little bit better than the stockings. So under the clothing, it can kind of see it. And that's why sometimes I'll tell people that they can also get Spanx. You know, it's not technically for that, but the Spanx are the things that people can wear under dresses to help just kind of, you know, flatten things. And but it can help also push blood up to the heart. Yeah.
Dana, are there any questions online? Nope. Is anybody online? Okay.
I have a question. I have a question.
Okay, Lisa.
How do you tell the difference between overactive bladder and too much water?
Yeah, that's a great question. So it can be tough. You know, most of the time people aren't overdoing it on the water. And I would say that if you're not used to drinking a whole lot of water, initially you might feel like you have to go to the bathroom more often. But yes, it'll lead you to going to the bathroom more often. But it's more so like that, like you're standing there and you just get suddenly hit with this urgent, like, I need to go to the bathroom now, or I'm going to have an accident. And so if you're hydrated, that's not necessarily going to happen. You just might have to go to the bathroom more often. But you're not getting this sudden urgency or having trouble emptying your bladder.
Dana, can we mute those, whoever that is? Unless they have a question. All right. I don't think we have any more questions. Can we give a round of applause? Wow, a round of applause for Dr. Kane.
Thank you.
All right. We are going to get Gina Blackwell up here, but before we do that, I want you all to do a little fun game with me real quick. Everyone put your pointer finger out in front of you.
This has spread. Make your meal, then add everything to cart in one tap. Ingredients and weekly basics included. No forgetting, no extra.
You're welcome. All right, put your finger out, pinky out, underneath, without moving your hands. Now switch them. And switch them. Don't move your fingers. Don't move your hands. All right. Take your hands out. Give me an okay sign. And give me a peace sign. Okay? Right in front of you so you can see them. Now switch them. I'm waiting for a middle finger. At this point. Or are we Richard Nixon and just trying to get you guys up a little bit. Gina, you ready? Melissa, did you mute? Did you turn this off? Okay. So Gina Blackwell, why are we not talking now? Gina Blackwell is from VCU, so she traveled out from Richmond for us, and she's going to talk about the research out at VCU.
One minute.
All right, those on Zoom, please don't unmute.
Hi, everybody. My name is Gina, and I am a clinical research coordinator at VCU. And today I'm going to talk to you about the importance of participating in research, and then I'm going to tell you a little bit about some of our enrolling studies that we have. So why should we participate in research? There are many things that we don't know about research, many things we don't know about the brain and about Parkinson's disease, and doing research helps us learn more about that. And even when we learn something that doesn't work, it's still important for us to know that information as well. Participating in research also helps us make advances in therapies. And if you were in the first session, you heard another doctor talk about some newly approved drugs by the FDA. One is Crexont and one is tavapadon. We at VCU actually participated in both of those studies. So that's pretty exciting for us to do a research study and then find out like just a few years later that it's available to everybody. Tavapadon's almost available. Additionally, it is important to have a diverse population of people to participate because treatments work differently for different people, especially differences in men and women. So we like to have lots of different people participating in research. Louder, okay. And so now what I'm going to do is I'm going to tell you about some of the studies that we are recruiting for at VCU. All of these studies are completed at the VCU Health Center in Short Pump. Okay, and research typically has three main parts to it. The screening part where you, the screening part where we understand what is happening, where you come into the research visit and you understand what's happening at the research visit. You understand what your responsibilities are, what our responsibilities are, and making sure that you're a good fit for this study. The next part is the treatment part of the study where you're actually receiving the treatment or observation and you're observed throughout the study following the study protocol. And the last part is the safety follow-up, which usually occurs a few weeks after you finish the treatment to make sure that there are no harms the study treatment hasn't caused you any harms. So also, if you had saw in the first study, in the first portion of the study, this is a treatment that she talked about this. This is a double-blind stimulated surgery controlled phase 3 investigating the efficacy and safety of a one-time investigational cell therapy called bendeneprocel on movement, balance, motor symptoms, and quality of life in people with Parkinson's disease. This is actually a disease-modifying treatment. The hope is that it will regrow your lost dopamine neurons and to improve your quality of life. Most of the visits will occur at VCU. However, you will have to travel to another site for the surgery. And this also has a sham surgery in case, because it's a double-blind surgery, you might not receive the surgery, the actual treatment. But at the end of the study, you will have the option to roll over and actually receive the surgery with the treatment. You may be able to participate if you were diagnosed with Parkinson's disease within the last 4 to 12 years, are between the ages of 45 and 75 years old, are taking a levodopa-based treatment to control your motor symptoms, and have at least 2.5 hours of off time. The next study is called Illumera. This is a randomized, double-blind, placebo-controlled study. Again, it's phase 2 for people who have Lewy body dementia psychosis or people with Parkinson's disease dementia psychosis. This is a 6-week treatment period, and following the treatment period, you have an additional option to continue in the open label extension and continue on the medication for another year. To be able to participate in this study, you need to have been diagnosed with Parkinson's disease dementia or Lewy body dementia, are between 55 and 85 years old, meet the criteria for psychosis, and have hallucinations or delusions, and have a care partner who can come to you and help you with all of the visits. The next study is an observational study. This isn't a treatment study. This is a study that is being done to better understand the psychological mechanism that drives cognitive fluctuations in Lewy body dementia. We're looking for 120 people to be enrolled, and for people who have Parkinson's disease, mild cognitive impairment, Parkinson's disease dementia, dementia of Lewy body, and mild cognitive impairment for Lewy bodies, as well as healthy controls. This study will be just 2 visits, I believe 3 visits to the VCU center, and do some cognitive testings and have some exams with the doctor, some biomarker testings, have an EEG for, I apologize, this is going to be multiple visits because you have a 48-hour EEG. And then you do the treatment again, like the observation again 1 year later, so we can track your progress. And to qualify for this study, we ask that you be diagnosed with either Parkinson's disease, mild cognitive impairment, Parkinson's disease dementia, Lewy body dementia, or mild cognitive impairment with Lewy body, are not taking benzodiazepines, and are able to have an MRI. And the last study I'm telling you about tonight is another observational study. And this study is looking to see if you have the Medtronic Percept DBS in your in the GPI. We are looking to see if we can find what it looks like in the brain when you have freezing of gait. So when you're trying to walk and you feel like they're stuck to the floor, we wanted to see if we can see the signals in the brain so that we can further make better treatments. Because right now, nobody knows what causes freezing of gait or how to treat freezing of gait. And so this is a new and novel thing that we're doing. This is just a one-time visit to the clinic at Shore Pump. And we just have you come in, and so it'll be a few hours, and put you through a bunch of walking scenarios that cause you to freeze. And to participate, it's really easy to get into this study. You just have to have Parkinson's disease, have the Medtronic Percept DBS implanted in the GPI, are able to walk independently, have freezing gait, and don't have dementia. This is my contact information. We have plenty of other studies also participating at VCU, more observational studies and other drug treatment studies as well. If you're interested in any of these studies or any other studies that we might have, please feel free to email me, call me. That's a cell phone number. You can text me on that. And I also have flyers for some of the studies that I talked about today.
Do you have any questions for Gina? So for that last one, you have to have DBS already?
Yes.
To be able to do that. And do you have to be a VCU patient to be able to participate? No. So even if you're UVA?
Anybody can come. I will talk to anybody about participating in any of our research studies.
Any questions online, Dana? Nope. Doctors, you have any questions? Peanut gallery? Nobody? All right, let's give Ms. Gina Blackwell a round of applause. Oh, we are going to bring Kim up. She was one that I had introduced earlier, and come on down, girl. Earlier, she has some information out in the lobby about a study that she is doing. She's going to talk about it real quick.
Hi, everybody. My name is Akim. I am a current PhD candidate in the Systems Engineering Department here at UVA. We're currently running a study about how people with tremor, Parkinson's disease, essential tremor, etc., use touchscreen devices, modeling that so we can make those devices a little bit easier to use. It's only a 2-hour session. You come in one time. That's it. If you have any questions, I have to leave after this, so you can spot, there's flyers with my contact information outside on one of the tables, or you can talk to Dr. Fagari at the back. He knows about the study as well. So yeah, thank you.
If you're on Zoom and you're interested in Akim's study, I'll have the flyer at the gym, okay? So if you're on Zoom and you can't get it today, we will give it to you if you're interested. All right, any questions on the last couple of presentations? All right. Laura should be joining on Zoom. Dana, can you see if Laura Z is on Zoom? She is, okay. I know you can't unmute Laura. Just give me a second.
Hello.
Hello.
Hey.
All right, so you should be able to screen share your computer right
Okay,
now.
awesome. Well, thank you all so much for having me. My name's Laura, if we haven't met. I'm here in the neurology clinic now. Sorry, I couldn't be there in person. So let me share. Okay, and can you all see this? I can't see you. Any feedback? Is it working?
Yeah, we have it up here.
Okay, awesome. So this topic of long-term care planning, I am barely just gonna cover the surface of it to hope give some buzzwords that will help like with your own planning or things to Google or things to bring to your support systems. So I will talk a minute about social work and what that means, define long-term care and how I'm talking about it, go over options and costs of long-term care. If we have time, briefly, palliative care versus hospice. So social work is normally the first question I get when I meet with folks that haven't interacted with a social worker before. It is by degree. So I have a master of social work. We have a code of ethics. Social workers exist in all different fields. They can be your mental health therapist. They can work in schools and child services. Here in the clinic, I work closely with the movement providers and other neurology providers about biopsychosocial needs, barriers to care. And so work closely with the occupational and physical therapists and just the whole treatment team in regards to some of these topics. So the cost of long-term care, transportation options, community resources, financial questions and concerns, lots of care partner support and emotional support. So these are the types of things that I might get referrals for from your provider after a visit, or if it's a multidisciplinary clinic, I might meet with you here in the clinic during your appointment. When I am talking about long-term care, I use that very broadly. So not just living in a nursing home. I am talking about assistance with activities of daily living, or ADLs, which is personal, home care assistance with these tasks. These tasks have a lot to do with dignity, with safety, well-being, cleanliness. And then the IADLs also have so much to do with quality of life, but are more, those are going to be the first tasks that if someone's experiencing cognitive impairment or it's becoming difficult with aging, that family members may be helping with, the spouse may be helping with more, keeping track of appointments, paying the bills, preparing meals. But then the activities of daily living will be things like eating, getting dressed in the morning. So these types of activities and support can be done in home or in a residential setting. There's many folks that can age in place and do that safely and live out their lives through Parkinson's disease at home. There's other folks that, based on circumstances or just personal preference, choose to move to a higher level of care and get that support in a residential setting. So the types of long-term care at home are often from family members. So we have millions, I think tens of millions of unpaid care partners in the country. So especially with cost, and we'll talk about how Medicare does not cover the cost of long-term care, but family members may help with the daily living activities, with preparing meals, getting to appointments, keeping track of appointments, to the more personal care needs such as toileting, getting dressed in the morning, taking a bath or a shower. So those services are also available by hiring home or personal care agencies. That would be locally Bright Star, Commonwise, Home Instead, that you might get advertisements for. And those agencies provide assistance with activities of daily living. They can also help with light housekeeping or meal preparation, so some of those IADLs. Another option to put in a care plan might be a day program. That will depend on someone's current functioning and level of care needed. That would be a place typically with more supervision, such as the JABA respite program, where you can bring your loved one and leave them. They're in good hands, supervised, supported, doing an activity, and then pick up at the end of the half day or the day. PACE is another option while folks are living in the community at home. PACE means the Program for All-Inclusive Care for the Elderly. Here, the company that runs it is called Innovage, but PACE is a big federal program. And that program includes a day program. It will pick you up, bring you to the day program, do all occupational therapy, physical therapy, meet with primary care. They manage your medications. It's all inclusive. For residential care options, might be assisted living or memory care. So those types of facilities are not healthcare facilities. They help with personal care, the activities of daily living. So those personal care services. Assisted living is very different than a nursing facility, as that is licensed by the health department. So it is going to be a little less homey than an assisted living, and there's a big difference in cost between those options. If someone with Parkinson's chooses to get a feeding tube, that's going to escalate the level of care beyond assisted living, because assisted living cannot help with nursing tasks every day, but a nursing facility would cover those needs. Respite is a word thrown around a lot, and that can mean a lot of different things. Respite means a break for that primary care partner. That can occur either at home or a short-term stay in a facility. At home, it might be weekly respite, might be one day of hiring a home care agency, or a couple nights a week, so that that care partner can get some good sleep. Short-term stay in a facility is typically private pay in either assisted living or nursing care. Those are businesses, so they want your money, so they'll probably work with you on making those arrangements if that primary care partner is going on vacation or needs medical treatment of their own and needs some recovery time. Sometimes the facility short-term stay is a minimum of 7 days, sometimes it's minimum of a month, just depends on the particular facility. So from the audience, I'd like to ask estimates of costs from someone who hasn't looked into these before. So any guesses on hiring a home care agency hourly in this area about how much that might be? Or can I see the chat? Can't hear anyone at this time. What about, oh, I see in the chat, 37 an hour. Okay, thanks. So for the PACE program, any estimates on that? So that absorbs your Medicare, and will cover all your care, and it's billed monthly. Not hearing any responses, so I will keep going. Assisted living or nursing? Assisted living is billed typically as a monthly cost, and then nursing facility is actually billed by the day. Can you repeat what you said about Medicare? Okay, so the PACE program absorbs your insurance. So that is something covered by long-term Medicaid, but it becomes your primary insurance and pays for all your doctor's appointments and things like that. So it is a large out-of-pocket cost. Okay, assisted living, at least $5,000 a month, at least. Long-term care, at least $10,000 a month. 7,000 a month. Okay, these are some pretty good guesses. So on the next slide, thank you for engaging with me. On the next slide, here are just some estimates. So home care assistance, if family members are not able to provide that care, there's folks that work privately in the field that might be 15 to 25 an hour. Agencies in this area are about 40-ish an hour. There'll be more for evenings and weekends and holidays. The day programs in this area are about 100 or more for the full day. Sometimes they're available for a half day. The PACE program, that is covered for someone with long-term care Medicaid, and we're going to talk about that a little bit, but out of pocket, yeah, exactly. PACE, you have to qualify for underserved population, typically dual certified, exactly, with Medicare and Medicaid. Out of pocket, if someone is not eligible for long-term Medicaid, PACE costs over $6,000 a month. So that is normally, it's folks that are low income eligible for long-term Medicaid. For residential care, I thought this little image here from a federal website was very kind. You know, with that estimate of $5,000 a month, realistically, I get quotes from facilities in the area, depending on someone's level of care need. The lowest quote I've ever gotten is around $4,500 a month, up to around $15,000 a month if someone needs full care in an assisted living facility, a higher end assisted living. For nursing, it is billed by the day. So that's going to be the highest level of care. Someone needs to be supervised by a nurse 24/7. And for regular facilities, it is between $300 and $500 a day. For specialty facilities, if someone is on a trach or event, full-time, those cost about $1,200 a day, and we don't have, the closest one to us would be about Richmond. But we do have plenty of assisted living and nursing facilities in the area. For respite, those costs vary because if you're not in a contract with a home care agency or a residential facility, they actually typically charge more than if you're committed in a regular contract. So the big takeaway is that Medicare does not cover these costs. So the personal care costs of things that preserve dignity with keeping you clean and comfortable, bathing, toileting, eating, that is not covered by Medicare. So the options to pay for that care are, if from any savings or retirement accounts, previously purchased long-term care insurance. With that, some life insurance policies do have riders that may include costs of long-term care. I've only seen that for very close to end of life, though, for terminal illness. Veterans benefits, if you are service connected and disabled, it might be possible to get services, a couple different long-term services through the VA. Another option is long-term care Medicaid, because most folks can't afford this high cost. Okay, so next, talking a little bit about long-term Medicaid, just because there's a lot of myths around this program. So again, it's a different program than Medicare because Medicare does not cover the cost of long-term care. This is a public insurance program that may pay for help with that personal care, home care assistance, either at home or in a residential nursing facility. This program may also pay for the PACE program if you live in a PACE area. The home care assistance, if you've heard a program that can pay a family member, it's not a lot, but in this area, long-term Medicaid can pay a family member about $12 an hour to provide all that support that we do for our care partners, for the people living with Parkinson's. Other benefits of long-term Medicaid are home modifications. They can pay up to $5,000 for like a bathroom remodel or a ramp, transportation to medical appointments if you can't get in and out of a car easily, or even if you can and have a family member bring you to appointments, you can submit for mileage reimbursement or use their accessible transportation to stay in a wheelchair. We'll pay for medications, medical equipment, things like that. The eligibility for this program is that you need assistance with activities of daily living, and then the financial eligibility is that not including your primary residence or one vehicle, you have to have less than $2,000 in any assets that you're able to cash out. So that would include any life insurance that you can cash out. How to plan for this is an expert would be an elder law attorney that can look, if you need the care within 5 years, which is a bit of a gamble to plan for, there might be different options because Medicaid does look back 5 years to make sure you haven't sold any assets for less than fair market value or given any money away. So there are some options with planning because most folks are in that in between where, you know, those numbers from the previous slide are alarming, but then you might have more than $2,000 and want to, you know, use your preferences with how you want to spend that money. So in 2 minutes, the differences between palliative and hospice and their similarities that they might be at the same agency. So in this area, we have Hospice of the Piedmont has a palliative program and they also have a hospice program. Both programs focus on your quality of life and are led by medical providers and covered by insurance. Palliative care is a special branch of medicine for people with serious illness at any stage of disease. And so the primary person you would meet with is a medical provider. For some agencies like Hospice of the Piedmont, they do allow you to use more of their programs. So they have volunteers, volunteer death doulas that you can access through that program. But it would mostly be just setting expectations, another provider that would meet with to talk about your goals of care, your quality of life, what's most important to you. For hospice, that is prognosis based for eligibility, and these are Medicare rules that someone's hospice eligible determined by a hospice agency about 6 months to end of life. Hospice is comprehensive care that includes a medical provider, nurse, home health aide, chaplain, volunteers, 24/7 hospice line, social work. They can meet, you know, if someone's pretty, you know, closer to the 6 months, it might only be once a week or less frequently to meet with hospice. Close to end of life, they can certainly come more frequently or every day. Hospice goes on your goals and what you want. So I don't find them pushy, but I do like to break the myth that it's not just for someone's last days of life. Hospice can be available for much longer than that, but at any stage of Parkinson's, if palliative would be something helpful to explore what medical decisions you do or do not want to address your quality of life and support for your family, that could certainly be a program to enroll in. For local resources for exploring all these things that I talked about, JABA has lots of wonderful information locally, or if you're out of this area, that's a map of all the different local area agencies on aging. For folks that are younger than 60, we do have centers for independent living across the state that are mostly disability resource centers for adults. Social services to apply to long-term Medicaid if you're not able to afford the cost of long-term care and your personal care needs. And of course, the park is a wonderful place to go and connect with others. And you all, for those I haven't met, good to meet you. But the website for the Virginia chapter of the American Parkinson's Disease Association, of course, Michael J. Fox, they have information on all these topics specific to Parkinson's, but the local resources can help identify any programs in your area that you might also have access to for help with all these items. So any questions, please contact the neurology clinic. If you're a patient here, and then I added some bonus slides, not sure if this is going to be sent out, but advanced directive is important, power of attorney is important. Those are two different things, and they're both also different than a DNR or a PULSE form. So just ask your doctor about that.
Or are you up for some questions if we have any?
Yeah, absolutely.
All right. If you're on Zoom, please put it in on chat. Do you have any questions here at the gym, in person for Laura? Crickets. Someone in the first session talked about the red folder. Is that right? So that's a lot about what you were talking about, Laura, where it's making sure like advanced directive and then everything is planned out. The person who brought that up in the first session is actually going to email me, and we'll send that out for everybody to have that. Any questions pop up on Zoom? Dana? No? All right. Can we give Laura a big old round of applause?
Thanks, everyone. Have a good day.
All right. So I'm going to share screen. Laura, I'm going to mute you, okay? Unless you already muted or jumped off. All right. So our next presenter is a professor and chair of the Department of Neurology. Some of you all have met her before. Some of you may have been in clinic with her before, but I'm going to introduce Shumei Wong.
Hello? Oh, it works. Thank you, Sarah, for letting me to present. Thank you for sticking around for a long day and keep engaged. So I actually, it's relatively new to UVA. I've been here 20 months, so still learning a lot of things. I came from Hershey, Pennsylvania, practiced there for about 17 years and took care of people with Parkinson's and grew older with my patient in their community. So it's absolutely a pleasure to hear to talk one of the topic. I hope it will excite you. Just around the corner, probably available for our Parkinson's patients and community in near future. First, as all the academicians, I can declare my conflict of interest in this topic. There is absolutely no financial conflict interest when I'm talking this project or this particular category of drugs. However, I have a major personal disclosure I want to share with you, so you can take whatever I say in the future, next 20 minutes, take a grain of thought in that personal context. So about 30 years ago, I was an intern in Veterans Hospital, Boise, VA, was there. And that moment of time, I already have an MD and PhD in neuropharmacology. And then in a meeting, neuroscience meeting, 1996, I met this professor. He said he's a neuroscientist at UNC, and he happened to study dopamine receptor. For whatever reason, he thinks it's important to go to China to meet my parents, convince them he'll be a good partner for me. He really spoke to their heart. And he also wanted to bribe that little niece I have, the only daughter, one child of my sister, who was 9 years old. He basically said, I will buy the most expensive food you love to eat. She chose McDonald's. So with that action, he bought my mom, dad's heart, and the little girl's heart. So 2 years later, I married him. So that's a story. So he also adopted dopamine. He actually, in a sense, I know a lot of dopamine. This is a slide from him. He actually every day lived this, what's happened to the dopamine? So in this community, we don't have, say, important word dopamine because of the key challenge in Parkinson's disease. For some mysterious reason, there's a dark neuron in the middle of the brain and disappeared. We still don't know the reason what happened. So a lot of my research tried to figure out what happened. But Richard Millman, my husband, asked differently. He said, how will we replace it? So you're all familiar with the levodopa. It was kind of godsend about 60 years ago to our Parkinson's community. Because for the first time, levodopa can somehow bring dopamine back to our brain. So I say levodopa, that's a key component of Cinemet, Rytary, and many things you hear. Actually, it doesn't matter what name, and state level, I think there's many other names, duodopa. And the moment you see levodopa, they work the similar way. Dopamine neuron in your brain have this important enzyme called tyrosine hydroxylase. So you eat your food, maybe the bean, that's an L-tyrosine, is become L-dopa. The L-dopa then become a dopamine. So what happens when Parkinson's affect us? that dopamine neuron die, and we don't have a tyrosine hydroxylase. We cannot overcome that called rate limiting factors, and we cannot make dopamine. So clever design was you give L-dopa back, bypass that steps, then just like down low. When you have L-dopa, your brain will start making dopamine. So that was the key fundamental chemistry of 1950 allowed the levodopa to come to us to replace dopamine we lost. So here's what happened. The question is, if L-dopa when coming in 1950s, 60s, 70s, godsend. Is actually inside the movie called Awakening, the book. We literally from frozen to running. So what happened when we're living this long enough? Why is starting not as effective? Why we still say Parkinson's still relevant to our life? Why just one levodopa for all? Here, probably the best one. This is also Richard Mailman made for me. He tried to explain to me when I first met him. The green bubble you see on the top, we call presynapse. That's where you're making dopamine. So a healthy person, we have all the green bubble there, so we can eat tofu, corn, the actually making levodopa, L-dopa will become dopamine. That's why we don't need levodopa. So early stage of Parkinson, we know for a fact, you can lose 50% of dopamine, you're normal. Most likely you come see doctor, become a symptom, you have less than 50% that dopamine cell left. That's the second stage. We have started trouble with the buttoning and the handwriting, the fine motor skill we lost. So that time, you still have 50% of working presynapse. It's pretending in factory, you have 100% staff, now 50% staff, but you feed them more. So when levodopa will be giving that rest 50% dopamine neuron more material. Say make more. So that's critical honeymoon period of time because you have 50% neuron left, 2 out of 4 men still working. They work a little extra shift. That's why you have the honeymoon for Parkinson's. So the advanced stage currently defined with levodopa is called when you're starting to have drug on and off. When you're the Parkinson's honeymoon set, you take a levodopa, you don't miss it. You're done, life is great. So you start feel the medication start wear off. You say, now from 5 hours, don't miss it. Now 3 hours, I need it. So more advanced stage, when that fluctuation happen, we define somehow that 4-man job only become because we may lose more. We have one by working. He basically say, I'm not that reliable anymore. I'm carrying 4-man's job. So literally, it just on and off fluctuation happens. So late stage is happens, all the men gone. Okay, so the levodopa have no place to go to convert to dopamine. Guess what it does? It go to take up other cell, convert, become serotonin, noradrenaline. Actually cause more side effect than effect when we get to that late stage. The currently definition of late stage is when we start depending on other people, caregiver dependent. So I think early today, you think about early stage, we're talking a lot of things. I know this today's theme is on later stage, what we do. I was happen to hear Lori talking about the resource for you, but that time we have nothing can treat short of supportive care. You can see the financial drag, the toll to our caregivers is a tremendous. So that's sort of a, why I'm thinking I'm excited what maybe the next few years hold for us. So let's go back to dopamine pharmacology one more time. So when you have a levodopa, it becomes dopamine. That dopamine ideas, we make dopamine to tell the next man. How I go back, yeah. See the gray? So the green bubbles making dopamine. The gray is called postsynaptic. So bunch of receptor there to taking dopamine, ready to be action. So they're called dopamine receptors. So turn out dopamine receptor, there's 5 types. Mother Nature dopamine hit all 5 types. But if you go to people like my husband, a dopamine nerd, he thought there's 5 different type of different functions. And mainly have one called D2-like, one D1-like. D2-like is 2, 3, 4, D1 is 5. So by the time when Richard was started to become a young scientist, this is a textbook of pharmacology. They all thinking the textbook, thinking D2-like is carry all the dopamine function. The D2 stimulation will help Parkinson's patient be normal forever. So D2 agonists, many of you are familiar with, like Miraplex, Requip, and a lot reticutin. So a lot of concept dopamine look like drug. If we don't have the manufacture of dopamine, can we just stimulate? So dopamine agonists, it try to say, we don't need to make more dopamine. We go to talk to the next guy. So a lot of all the past, I say 30 years, all the dopamine look like agonists, all focus on D2-like, based on this textbook. And Richard, before I met him, 15 years before I met him, he said, I think D1 is important because he based on all the available, he profiled all the dopamine receptors, found they all majorly D2 activation. The best thing resembling help, levodopa had everything if you can convert it. But you don't convert, maybe apomorphine and actually have resemble had the best effect and hit some D1, but because D2 property. So he hypothesized D2 property may actually responsible for a lot of hallucination, confusion, sleepiness, drowsiness, impulsive disorder, but D1 helps more clear. But he cannot test this hypothesis until there's a drug can target D1 receptor, D1-like, D1, D5. Long and short, he collaborated with my PhD advisor, who is a medicine chemist, and found the first ever genre of drug only hit D1, D5 receptor in 1989, right that time. And then they allowed them to test the hypothesis. They went to the human. These 2 drugs around that time made a human. Yes, for the first time, we see a drug match the levodopa side effect. And it's short acting, but prove the principle. But that's 1989, thinking about, right? Why we didn't see that for the past 30 years? Because also drop the blood pressure. This drug was an IV. What they did, the first experiment, put the IV drug on the dopamine, everybody went to ICU because the blood pressure dropped. So although have this anti-Parkinson's effect, but the intolerable side effect got all the scientists frustrated. So fast forward 10 years later, he met me. I saw the movie, and this is 3 people. Richard Mayoma is my husband, and David Nichols was my PhD advisor, made that first D1 agonist. That's me. I was become a believer. I think this actually start writing an article. D1 might be the thing for Parkinson. We can work on the side effect, make it happen. That was 25 years ago. So, and then how to bypass you give your IV injection of dopamine drug. Can we actually get rid of side effect, low blood pressure? So I was thinking long and hard, don't want to give up this perfect target. So I started working with Malin DeLong, one of the most he just passed away a couple years ago. If he's living, he probably get Nobel Prize for his work for Parkinson's. He was my mentor. So working with him, I say, what if we give this drug, not the IV, just put in the fat? And so we can slowly release, we can get rid of a side effect of the low blood pressure. Indeed, it happened. So based on that, for the first time, human can start tolerate this drug without go to ICU for low blood pressure. So I was so excited when this drug actually not only tolerate, for the first time, psychiatrists using not only that didn't drop their blood pressure, it's also helping their working memory, meaning all the things spell world backward. There's no drug in human have ever helped the working memory. It's the first drug not only cause confusion, but help the memory. I was so excited. I wrote this article. So 2004, as the first year young assistant professor, I was, Dr. Mailman, Dr. Nichols are basic scientists. I was the first part clinician in that team. It's been a believer. I basically wrote this for Parkinson's Foundation. I said, D1 agonists hold the future for Parkinson's. That's 2004, okay? So this is a long journey. And from then, and we never give up. So Richard and literally talk with every drug company possible to don't give up the target. Long and short, when 2017, actually he educated every company. So Pfizer say they have the drug. There are 3 of them, all human ready to be testing. So Richard was one of the keynote speakers in 2017 to guide through what the next will be. So from the Pfizer, when Pfizer actually sold the company, the right for the D1 agonist to Cerevel, passed three phase trial, and just on the verge of getting to the next stage, AbbVie actually owned it since 2024. That's beyond my knowledge of how this works in the business world, but I'm so glad to let you know. Today, 2026, 3 large phase 3 trial test the first oral available D1 agonist. Is 1 pill a day, oral, match levodopa's efficacy in all. They didn't do heads-to-heads, but from the curve, is really have not seen a drug can match levodopa efficacy. Once a day oral medication. Those 3 trials is so exciting and propelled the IND FDA filing in last year, right before government shutdown. So maybe we're a little slow, but my hope is later this year when government resume more function, within next 12 months, it will be come to our available to Parkinson's community. And last week, I was in Chicago for AAN meeting. Here's what happens. For all the patients in this first D1 agonist trial was offered open label study, means they continue offer. So those patients have on drug for the next 40, 50, 70 weeks. They show the result after the open label follow-up. Namely, the people have never on Parkinson drug before, on this drug, they literally don't need levodopa still. That means it does carry the weight as levodopa. For the people already on levodopa, other drug, as add-on, they don't need to change their medication. So sounds the D1 receptor carry the weight. So I'm so excited to see this new category drug can do for our Parkinson patient in the community. So this is a summary of, I try to make sure of the transparency because of what this is the most observed common side effect from this first of kind genre drug, similar to all the Parkinson dopamine drug. Nausea, they say common means more than 10% people get it, or 9%. Nausea, headache, dizziness, and taste change, tired. But some less frequent the side effect, including low blood pressure, hallucination, but they all sleepiness, some impulse control. But majority of people are tolerate well. And just circle back to the late stage. So if D1 really hold its promise, doesn't have the D2 function. Could that be less hallucination, confusion, helping the working memory? What it can do to our late stage patient, the one needed caregiver, the one supporting care is only our option. So ask the question. I don't know how lucky I got it. I think I show a picture of my patient on wheelchair. I went to Pfizer. They literally not only gave me the drug, they also fund my study in 2017. So we published 2 papers on this. This is the first ever any people have using do a drug trial, people in the late stage. Remember, this late stage defined on caregiver dependent. Those are patients also we have been optimized every drug we know. If they need a DBS, we did a DBS. And even that, they just become wheelchair bound. They just sitting there doing nothing. And so we have 8 brave patients and their family participate study, first of kind. So this is the result. We actually compare with the levodopa. And we actually turn out nobody ever done this kind of study, so we don't know the scale. So the clinician do the regular tap, tap, tap for 5 minutes, go away to see the drug make differences. And the study is 2 weeks in our like a neuro study group. So the caregiver there be with them for the 2 weeks. They tell us they don't know what drug they get. Is that make difference or not? So the clinician, the blue bar, the grayish darker bar is people on the drug. The open bar is people on levodopa. Both clinician and caregiver rate the D1 agonist is better. So this one we published the result, but I do want to show what it looked like in that trial. So literally 1 week, the patient on the drug, the other, the new drug, the 1 week they on levodopa. I don't know what the patient get, caregiver doesn't know, patient doesn't get, no. Actually, our nursing team doesn't know. Only the pharmacy knows. So this is the video translate what I saw, why I feel hopeful.
Because the girls were in here talking and he was upset because he couldn't get his
This
words
is the
out.
levodopa week at end.
So
hard to get a word out.
Yeah.
But this the patient had DBS, had levodopa, nothing worked.
But this is
stayed
very
just like
similar
this.
to at home, right? That's the thing. So when the draw, it's harder to get a word out, right?
Yeah. But even when his mouth isn't drugged, he still has trouble
Get the word out, right?
to get his message across to me, and that upsets him.
That's upset, yeah. So he said it's really well this morning. He said, I want to feel on top of the game. You know, he doesn't feel that way. You want to share something with?
He's doing good. He's just like his old self.
What do you mean by old self? Old means a couple years ago, or old like last week?
Well, no, a couple years ago.
You think so? He's like a couple years ago?
Yeah, he's got that smile, that happy look. You know, where Parkinson's patients, you know, how they look, just more.
So you think he's more vivid? You think he look better? I think she's biased.
See, look how he smiles.
Yeah. I tell you.
So that's for example, that patient family allowed me to share that. We have 8 patient was in that latest stage. And the lesson I learned, I couldn't get compassion use afterward. The effect for that patient is so dramatic. His wife had been calling me since I got compassion use. I was try, didn't get it. He ended died with cancer from broke my heart, but also a lesson learned to be in the any future study, I need to get open label at the end. So not know something help, but I cannot giving to them. But I'm so looking forward to this drug can be approved for FDA in near future, and our community can learn what it can do for us, we can do better. So here's my family 30 years later. So Richard and I, and all both moved to Charlottesville, become a professor of UVA. And so Richard's passion is to learn what happened with the first generation of D1 agonists, what we can do better. Can make get rid of side effects. So he working actively, the scientists fishing to, you guys can tell us what we can do better. So we can do designer drug, get rid of certain side effect. And so that little girl, 9 years old, and she's 37 now. So the one like Kentucky Fried Chicken, the one. So she's right there. She's an architect in New York City, helped design a lot of the architect to make things look more beautiful. And Richard's, my stepson, and when I first met Richard, he was 15, so I raised a teenager first before I had 2 more kids afterward. And he gave me a beautiful grandbaby. He just turned 10. He's sitting on my lap. And so it's having an amazing journey. It's a scientific, personally, just wonderful. I think this community, I grew older and learned the science and found my community. So Richard and I looking forward to not only help Parkinson's community. As a chair of neurology, my dearest wish is increase access for care for everybody. So one of the things you can see whose license this year we have. Richard is up there called D1 is the one. He been heartstrong for 40 years on that. So he got a license for UVA. Mine is called Neuro First. So you saw my car. My Neuro First meaning is improve access. So 30 years ago, I didn't want to become a neurologist because I thought we only give bad diagnosis we cannot treat. So Richard Mailman say, honey, NIH just put a decade of brain, a lot of money to start neuroscience. Be a neurologist. I bet when you start practice, there's a lot more way to offer. I'm glad he told me that. Can you imagine right now? Everybody wants to see us from multiple sclerosis to Parkinson's disease to myasthenia gravis. We can offer so much more. So what Richard Mailman predict neuroscience brought better treatment. We're realizing that. So we're building a neuro first. I hope it's UVA brand. First time means first initial return subspecial care. So that's been piloted in the UVA grant since I become a chair. I'm happy and proud to report to you for movement disorder care are waiting for new patients in less than 1 month. Across nation never happened. So on average, everywhere else, if you see a neurologist for a movement disorder specialist, 6 to 9 months minimal. So we'll continue with this wonderful team of people sitting in this room. We're hoping we improve the access to care and pushing our envelope. Thank you for your attention.
I know that there are a couple of questions that came through via Zoom. So Dana's going to ask what came up on Zoom.
We have a couple of minutes. If there are any questions, we can have a conversation. Okay.
Okay, so the first question from Zoom is, will tavapadon replace carbidopa-levodopa, and when will it become available?
I'm hoping soon. Actually, when I start this journey, I told patient, I say, latest 2024. What happened delayed that 2024 was pandemic. So when tavapadon went to clinical trial and then COVID-19 happened, that's delayed. Second thing, strategic reason, Ukraine was a site. So when the war, Ukraine happened, that delayed that too. So one pandemic, one war delayed it. But nonetheless, that 3 trial all done. It's in the FDA's hand. It's sent to FDA in October, then government shut down, so delayed a little more. But I'm really, really hoping coming this year. It's really in sight. Can that replace for levodopa? The first trial is the patient have never seen levodopa, this drug, and really dramatic improvement. I just saw the data last week, even 50 weeks later, they don't need levodopa. Yes, actually I hypothesized it will replace levodopa, but real world data is still yet to see. Once a day, oral pill, you cannot be. Levodopa, how many times we do? Minimal 3 times a day. And I really feel unconscious to ask my patient to put the clock, live the life living around clock levodopa. From that per se, I thinking it truly can be a game changer for us. So that's, hope that answered the question. Can we replace if you can switch from levodopa to it, we don't know yet. There's no such trial ongoing yet. My hypothesis with disease, progressive levodopa may have more side effect. We may have no choice, but switching something have no side effect. We'll see. The real world experience is waiting for us to understand.
I'm sorry, there's just one more from Zoom and then we'll give it to the room.
Okay.
Will buntanetap still have a role in stopping the misfolding of alpha-synuclein proteins?
Yeah, I don't know the name, how you say the name. Alpha-synuclein folding hypothesis as cause Parkinson's have been going on for, I think, for 10, 20 years. I keep open-minded what those kind of category drug will do for us. It's a different research question. This is a very laser focus on how to replace dopamine function. And that alpha-synuclein folding is how disease start and the prevention. So I thinking maybe selfishly as a Parkinson's specialist, my goal is lift my patient already diagnosed, but there are a lot of effort to prevent the disease from de novo. So I will not make too much comments. I'm thinking it may happen, but probably after my time. Yeah.
I know we had a couple of questions, hands raised. Douglas.
How would you say this new medication is going to change the role of DBS and patients' decisions regarding getting DBS, given the non-specificity of the lag in its deployment?
Yeah, thank you for that question. I don't know the answer. The first part, when the 8 patient went to my study, that patient, the video saw, he had DBS already. So he did levodopa for about 15 years. DBS carried him for a few more years. So at beginning, my hypothesis was if DBS, you did DBS, a lot of things, this drug now work because it's ruling out the downstream. But I was so delighted the D1 agonist still work even after DBS. So in that sense, having DBS doesn't, at least I think it would not prevent D1 works. If you had D1, you would not have DBS or not. I don't know the answer, but current data shows that if you have levodopa, if you have D1 agonist, you don't need levodopa anymore. DBS at this moment is indication when people have motor fluctuation, you have levodopa-induced dyskinesia if you don't have levodopa anymore. So the jury is still out. So if the world ideal place, I can dream one day a pill carry all of it to 120 years old. So I think we'll see how it goes, one step at a time. But I think after 30 years, we're here today, finally, yeah.
Any other in-person questions? Another one on Zoom?
This question is from Wiley, and I think it's referring to Tavapadon, asking if you see the dose as IV or a solid dose.
Tavapadon is a pill, one pill a day.
One pill.
Yeah. So all the first generation, the part of failure to get pharmaceutical company engages the IV or injection, even sub-Q. That's not very convenient, and half-life is very short. Tavapadon has a beautiful half-life just once a day. So in that sense, not only the formula, the half-life receptor profile is pretty ideal for the first one. However, I don't know other things. My hypothesis is the first of a kind. We can tweak more to maybe second, third, depends on our experience, our wish list. And right now we have more scientists working on drug design. So once we know the first generation does for us, we can put some wish list what we can tweak more. Yeah.
Any other questions? Going once, going twice. Let's give a round of applause for Dr. Wong.
Thank you. Thank you. Yeah. Yeah.
For those who are on the panel, go ahead and start making your way up. We are going to set up some chairs, so just give us about a minute or two to get everything situated. Check, 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 check. All right. So our last part of today is going to be a panel, and we're going to hand out microphones. We have another one, right? Lauren, can you grab the microphone on that? Yep. All right. So who's on the panel for today? Wow. Dana Morrissey is a licensed social worker, and she will be the moderator. And then we have Marianne Lincoln, who had 14 years of caregiving for someone who had Parkinson's, who's recently passed away. Gina Moranto, who has been a caregiver for her spouse, who has had Parkinson's for 24 plus years. Jim McNeil, who's in the brown, he's had Parkinson's for 7 years plus. And Robert Speckman, who's right in the middle, he's had 30 years of Parkinson's, or has had Parkinson's for 30 years. Let me get that phrase right. You guys are going to share microphones probably. You guys.
Thank you, Sarah. I just want to quickly thank Sarah and the whole park team, and also Naomi and Joel and everyone at APDA that put this event together. I think I speak for the whole team at UVA by saying that we're really honored to be a part of it and so happy to be here. My background is in social work, and I work in the movement disorders division at UVA to help develop programs that provide wraparound care for people living with serious illness and movement disorders. So Sarah asked if I would try to moderate this panel, and I'm going to do my very best with the help of these kind folks. Sure. Okay, I wanted to start with a quick icebreaker question. If you could name an MVP of your Parkinson's journey so far, it could be a person, place, or thing, except it can't be Sarah. What would you name?
An MVP, well, I think it would have to be Mark. Mark has borne up with 24 years of Parkinson's with more grace and courage and humor than I could possibly have ever imagined. And as we go through this together, I'm called the care partner, but in fact, he gives me a great deal of care too. And so he would be my MVP.
My MVP would be my wife, Susan. She, hello, can you hear me? Okay. Mentioned that would be my wife. She's been there from the beginning, and it's not been an easy ride.
I agree with that, with my wife, Marianne, who takes care of me, babies me. And sometimes it's a little difficult to make sure that you don't take advantage of that.
My MVP was my husband. Of all the jobs he did, as a land surveyor, planner, whatever, but his most important job was the last 14 years of his life, because he lived it with such dignity and looked out for his family, but always had a sense of humor. And that's what's so important to me and to our family.
I wanted to start with asking about what you might wish your clinicians or your therapists or anyone on your healthcare team might have known about you from the outset, or known about your partner with Parkinson's or your family, that would have changed the way they cared for you.
Well, I can tell a cautionary tale. When Mark got diagnosed 24 years ago, he was 52 years old. He had been an incredible athlete his whole life. We were ready to go to Europe, and he told me, don't come with me to the doctor. I don't think anything's going to happen. He thought he was having muscular problems, you know. He had already had surgery on his toe and various things. So I didn't go with him. He came back, and the man had said, I'm not going to name the name. He was a very famous clinician who should have known better. And Mark said, what shall I expect? And when he was diagnosed, it was quite common that people would say, people with Parkinson's should not exercise. Precisely the wrong piece of advice. And so Mark said, what can I expect? And the guy said, you can read my book. So he sold Mark a copy of his book. We went the next day. Unfortunately, we had to put our dog down the next day. Our dog, our 15-year-old Catahoula leopard dog, it fell down the stairs twice before we were scheduled to fly to Europe. We had to put him down, and then we got to the plane. We had took off, and I said, okay, I'll read this book now. And I started reading the book, and it said, you will drool, you will lose your functions, you will need to pray to God and read the book of Job together, at which point I burst into tears. And Mark said, what are you doing? I said, I'm reading the book. He said, boom, he hit the light for the flight attendant. Champagne. Well, no, the lesson is not our clinician should have told him to drink more champagne, although, as John Maynard Keynes said in his dying words, what did he regret? Not drinking more champagne. But I wish the clinician had actually had an awareness of who his patients were and what Mark is not an early Parkinson's patient, but I wish that he had shown greater understanding. It took us many years to get to find a clinician who really understood Mark as a person and his needs. So that was our story.
I know who your doc is, by the way. If he's the UVA doc, I had a similar experience. Okay. Let me start by saying that the major event for me is my speech. I've always stuttered, but since the last 9 years or so, it's gotten very bad. So I ask you to bear with me, if you would, please. That's one thing that is altered over the years. The next would be my executive functions have slowed down some. I haven't used an automobile in 5 years, and I really miss that a lot. It's a lack of independence that I lack, and maybe that's a redundant sentence. And the last thing would be, let me see, executive functions,
Robert, is there anything that you wish you had shared with your medical team very early about who you are or how you wanted to be cared for that you didn't say?
I was early set, so they knew me very well. In fact, UVA folks have been very, very good to me over the years.
I'm glad to hear that. Why don't we move on to Jim to answer that question about advocating for yourself and sharing yourself with your team, and then we'll go back to some more topics. If that's okay with you, Robert?
That's okay.
Is that okay?
I'm going to talk about when I was first diagnosed with Parkinson's. Actually, I went to my GP because I had a little tremors in my arm. And he said, you have essential tremor, and kept saying that. Put me on tremor medicine that didn't do anything. It would have been a lot nicer to have him diagnose it correctly, but eventually we just said, let's go to a neurologist. And they made the announcement that I had the disease. Over time, it's gotten a little bit worse. And, but it doesn't, I try not to let it slow me up too much. Although my balance is such that it forces me to move a lot slower than I normally would.
When Tom was first initially diagnosed, we thought it was tick disease with the symptoms. And hindsight, almost 18 months to a year, we were going to see this quack in Charlottesville. And as a nurse, I was like, oh, somebody said he was good. He, checked him out for tick disease, and he kept saying, we're going to treat him the first line with an antibiotic, and if that doesn't work, just like in the Army, we're going to go to the second line. And I'm like, wait a minute, what? And this man wore a silk suit. I should have, you all know me as a New Yorker, and I was like, anyway, so Dr. Wooten was trying to tell me that no, can we test him for Lyme disease? And Tom didn't have it anymore. So that was a big awakening because Dr. Wooten knew and Tom knew that I would always be an advocate for him and speak up. So the docs knew, whoever we followed, knew that I would say, wait a minute, my gut says this doesn't sound right, or we got to do something. But in the beginning, I was in denial, and we were just going after this tick disease. You know, he's going to get better. He's going to get better. The other thing I want to mention is this was a disappointment with the support group, and it wasn't this support group through Park. It was another support group initially. And there was a former land surveyor in the group whose wife had Parkinson's. And in every support group, you always have this saying, what is said in the support group stays in the support group. And this man thought he was pretty savvy, and he went and he reported it to somebody else, another surveyor. And this Tom was early in his diagnosis, and word got out. So we were at a funeral, and people kept saying, "How's Tom?" "I don't know, he's fine. Can you see him? He's walking down, he's fine," because this had leaked out of a support group. And that really hurt me because I was very cautious about support groups. So if you do a support group, and I know Sarah speaks about it, keep it there, because Tom was not ready to let people know in the community that he had it. And everybody's different with that. And it may take 2 years before you want to tell the world that you have it, because you don't want sympathy. It may take you another 2 years or maybe the same time to do an exercise class, because you got to get better. And you need that time to accept it. But you have to respect what they're sharing. And but other than that, I felt every doctor that we met or we followed knew that we cared and we wanted to do the best for Tom. So
thank you. I'm curious if anyone else has an experience that stayed with you around sharing your diagnosis with your friends or your family or your community, like Mary Ann shared.
I was worried that if folks would watch me shake, my consulting income would vanish. And youngsters, I wanted to prepare them for college. And luckily that did not happen. But there was a concern that I had that my income would just fall to pieces. One event that I'd like to mention is that I'm an emeritus faculty member from the Darden School of Business, and we do a lot of executive education there. And I was running a sales force management seminar, and the last night we were sitting around and they asked who I would vote for in the next election. And it wasn't this year or next year, it was back in the 90s. So it was one of the drug. His last name doesn't matter. And we went around the room, and then it was my opportunity to speak. And I said, I'm concerned about stem cell research. And they asked me why, and I admitted I had the disease. They started asking me, what's it like? What do you do? You know, that's not the same, that kind of thing. And the next morning, as they're leaving, they hand me an envelope, and it was $1,500 made out to the neurology department to support research in Parkinson's. And the amazing thing for me was 5 days earlier, they didn't know each other. They just rallied around. And as the years have gone on, I've had this illness for more than, I'll be 79 in a couple of weeks. I've had for almost half my life. That's a long fucking time to have Parkinson's disease, let me tell you. And it's made me much more humble. It's made me more compassionate and a higher degree of empathy. So if I had to do it all over again, I wouldn't wish this disease on anybody, but life's been good to me. That's all I want to say for now.
Thank you. Gina, did you? Does anyone else? Jim, do you have something?
Just the Parkinson's has prevented me from doing a lot of the things that I used to love to do, whether it's working around the house or going sailing or traveling as much as I would like. But I've met an awful lot of really nice people that are they care about you and are interested in you. And it's been a positive, but it's very frustrating because you know it's not a curable disease. It's not like having a cut finger and it'll heal. And that sort of hangs on you.
Jim, you just said that you haven't been able to do all of the things that you wanted to do. Are there things for all of you that help to keep you grounded and help to keep your sense of self, your quality of life high, even as you're experiencing symptoms and changes?
Exercise. I do rock steady, which I'm very thankful for. I lift weights. I have a yoga practice. I get involved in martial arts. What else do I do, Susie? Oh, I do acupuncture. I get massages regularly. I see a network chiropractic doctor. The hardest thing for me is scheduling everything because it's hard to do all that. But I used to ride my bike a lot. And fell and injured myself, so I stopped riding my bike. You know, I will I'll hit the ground every now and then. And my knees are arthritic now, but they're, you know, they have lumps in them. That's when I want to be more helpful around the house than I ought to be. You know, I don't get on ladders anymore. I don't do other things that are stupid, that I shouldn't do.
Robert, what does the exercise do for you, emotionally and mentally? It sounds like it helps you feel like yourself. Do you know why?
When it's a sense of friendship I have with the other members of Rocksteady. It's something that I'm able just makes me feel good. You know, it's hard for me to articulate that.
Makes sense. Marianne?
I think one of the things that helps me is patience, which is, I think, a virtue. It's something I had to learn. I was a very impatient person with myself and with others. And the patience is not just for, you know, Mark moves more slowly, so I need to be patient with him as he executes tasks. It's patience with my own shortcomings as a care partner, and realizing that I'm much better at doing this than I used to be. I have to say for Mark, it's really been the last 8 years of the 24 that he has really needed more attention, more time. I didn't have children because I realized I was too selfish to have children, but you know, the cosmos kind of dings you whether you want it or not. So, and I didn't have I'm not of the generation that had Tamagotchis, so I had very little caregiving experience. So I was bad at it when I began. And I think patience, I always had to say, okay, do better next time. Don't be so fussy, you know, and that giving that sort of grace to yourself as a care partner, I think is essential. The other thing is you got to get away sometimes. Much as I would like to spend every minute of every day with Mark, it is essential for both of us that I go once or twice a year and see friends. I just went up to New York City, of course, with care prices being what they are. It was a very short visit. But I think those are things that, you know, being a care partner is not natural for someone who hasn't had children. I think people who have had children are a lot better at it, and because they know how to put somebody else's priorities first, and they've had to when their kids were growing up. And I think the difference with Parkinson's is when you are caring for a child, you know that the child is going to master the task and then move on usually if they are not a person who's otherly abled or non-neurotypical. And so, but with someone with Parkinson's, you know that the task is going to be more difficult to do over time. But I think it is a journey, as everybody says, and I think being patient with oneself and recognizing that you can always do better and also be honest about your flaws. I say to Mark, I'm sorry, today it's a really bad day for me. I can't do it as well as I might want to. I have other concerns. I'm anxious myself, whatever. And so keeping that communication channel over so that he knows it's not him, it's me. And every day we just get up and do it again.
I was asking about what helps you stay, to sort of maintain your sense of self and keeps you grounded.
I learned that I need to make time for myself. And I do that artistically with creating fabric art quilts. And I found when I can do that, I get lost and it's like a meditation, and it's just something that I've held on to. But the last few months of Tom's life, I didn't do it as much. And I'm finding now I have to catch up with my self-care. And the most important thing is it's okay, and don't feel guilty if you have to have a break. We each need a break from one another, but we also, we have to fill that vessel so we can give to others. And it's something that, because you love somebody, you're going to take care of them, but you have to take care of yourself. And but sometimes when the train is going really, really, really fast, you're holding on, and you just have to kind of, I'm learning now that I have to create my boundaries and to say no, and to say, I've got to take care of myself, because then I can take care of my husband, or I can take care of my kids. And that's so important, but you lose sight of it. And so I encourage people to, even, you know, with Tom wanted, Tom wanted to fly drones. So the first time we did drones, he did, because he really wanted to do it. Got up with his friend, and they were doing it, and then they lost his drone. And then we were flying drones in a batting cage. It was the best thing because it couldn't go too long. But he was so happy flying drone. And then I couldn't figure out how to do the control, so the girls had to do it. But he was, so then my son, I'm just telling you, Tom just was so mechanical. He wanted to do stuff. So my son got on this electric wheelchair. Oh, geez. So we're taking the electric wheelchair up on the walkway in the path, and Tom is so happy, and he's like this, and he's like this. And I'm like, I think we have to turn this around for safety issues, because it was just way beyond. But he was happy that he could get into the electric wheelchair or get into that electric cart at Lowe's and not destroy anything, but let him have some fun, and to recognize what you want to do and do it, you know, don't hold back.
You all are touching a little bit on the relationships that you have with your spouses or your care partners. I imagine they've changed a little bit as your illness experience has changed. Are there things you can recommend about how you've stayed connected as partners, not just as care partners, that might be helpful for people to hear?
Doing things, putting on coats, getting dressed in the morning is a little bit more difficult than it was when I was younger. And asking for help to put a coat on, or 10 years ago or 15 years ago, I would have not allowed that to happen. But I've become a lot more asking, I guess, because it just takes too many hours out of the day to try to do it myself.
We've established a routine over time, which works out well for both of us. And we love each other, so I think that makes it a lot easier. I have a funny meditation story, if I may. In 06, I had surgery, and I had a mantra that I was going to use, because you're awake for the surgery. And it was to relax me. And I was so relaxed that I wasn't showing any movement at all. And the doc said to me, whatever you're doing, you have to stop it, because we need to observe you. You know, so that was after a conversation of why surgeons ought to learn how to use power tools better, which I asked them to stop talking about because I didn't want to hear about that at all.
You said that you and your wife, I'm sorry about this feedback, I'm not sure where it's coming from. That you and your wife established some routines that work for you to help stay connected. Is there anything you can pick out of those routines that might be helpful for other people to hear? I know it can be hard to stay connected as spouses when your relationship changes into caring for one another.
One routine that I recommend you not do because they had me on some medication that made me hypersexual, which really hurt my relationship with my wife. Luckily, I didn't stay on that medication very long.
Actually, Mark and I have had to change. Both of us were writers for most of our professional careers, and that meant we sat alone by ourselves for many hours in every day, usually working late into the night on our projects. And he never really used to like to watch movies very much. He found them boring. He would rather read. He liked to read the longest volumes he could possibly find. So Man Without Qualities, Proust, whatever was over 1,000 pages long, that's what he would read. And actually now we watch streaming video a lot, and that is something that we can share, and we debate about which of the horrible series we're going to watch. But lately, I'm sure as you all know, Shrinking, Michael J. Fox, fuck Parkinson's. Highly recommend it.
I agree with you on that.
We can all connect over fuck Parkinson's, I think.
If I may, I've written a story of my life with Parkinson's, and I thought that I'd share it with you. This is it. It's less than 1,000 pages. And it's an easy read. And those of you who have read it, I think would say it's a good book. I'm sorry for being a shameless self-promoter.
Is there a copy under everyone's seat?
No, there isn't.
Yeah.
Yes.
Where can we get it?
On Amazon.
Okay.
It's available on Amazon.
We're running out of time, so I just want to ask one more question. If you had one word of advice about how to start difficult conversations about planning for the future, or how you want to be cared for, even something that you're needing from your community or your care partner that you're not getting, what would you give as advice to people?
I would start early and start with some plans, and whatever they plans are, put them in writing with the lawyer, whatever you have. Make a couple of copies. Put one where it's visible in the kitchen and one in the car. So when you're traveling, if something happens and your husband or your wife do not want to be resuscitated, you have it right there so you don't have to watch that going on, okay? Just communicate when you can now, and each of you should find a goal or something that you want, a purpose. that's happy, that the joy. We connected at night. Tom knew I would sit and watch TV with him, some shows. He knew it was our time, special time. That's how we connected. But I don't mean to be meandering, but these decisions are really important, because when the professionals come in and they ask, do you want more life-saving procedures? No. Do you want an NG tube? You have to decide if you want that or no. And we both said no. And that was easy when we could, we've got all our mental capacity. Tom, the dementia was coming in, and I was so glad we made these decisions early. And it was done and sealed away, but you can do it, and do it for the love of both of you in your relationship. And then go out and have a good dinner and a glass of wine or beer, but to enjoy life, it's done.
Champagne.
I agree. We've had those decisions already and have everything in writing, and we're all set to go. Literally. I think that's a true statement.
Did you all use any guides or tools that were helpful to you in doing that planning that you would recommend?
Something about the 10 wishes?
The 5 wishes, yep.
5 wishes, okay. And then also the lawyer had some really specifics for the state of Virginia, which were great. And but just make sure you have all the dots connected before you really have to do it, and it's just crazy,
We use an attorney and have everything.
Agree with that. You just do it. We've been a lot more open. 10 years ago, I was telling my kids anything about what my financial situation is or plans or anything, and that's become a lot more open.
Thank you all so much. Does anyone have any closing advice or words of wisdom?
Never invade Russia during the winter. Never invade Russia during the winter.
We'll end on that. Thank you.
You thank our panel and Dana for moderating it.